Good afternoon, everybody. Thank you so much for joining us for the first session of Family Council's Ontario 2025 Innovation Summit. This year, the format is a little bit different. As you may have noticed, we are hosting four different webinars all week between 12 to 1 p.m. And this is the first session titled Improving Care and Services in Nutrition, Food Service, and Dining, co-hosted by Ontario Seniors Nutrition and Advocacy Committee. My name is Taeyang Jang, and I am the Bilingual Events Manager at Family Councils Ontario. So before we start, I would like to take a moment to recognize the land on which we are gathered today. I am currently in Toronto, which is seated on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. So before I pass the floor to our guest speaker, Dale, I wanted to share a few logistics and housekeeping rules. First, you will notice that everybody is in listen-only mode right now. There will be reserved time after Dale's presentation for an interactive question and answer period. During that time, I encourage you to use the Q&A box to ask your questions, and you can also use the Q&A box all throughout the presentation to ask your questions, and we will get to it at the end. And there's also a chat box feature. So if you just want to chat with us, share some ideas, comments, if you have any like logistical questions or technical questions, you can put that in the chat box. I have my colleague Yoan with us today, who will be monitoring the chat, and I will also be monitoring the chat. And as you may have noticed, the webinar right now is being recorded. So it will be available on Family Council's Ontario YouTube channel in the coming weeks. So if you have not subscribed to our e-bulletin yet, we have a weekly e-bulletin where we share all of the updates and information. When the recording will be available, it will be shared on our e-bulletin. So now it's my pleasure to introduce today's guest speaker, Dale Mayerson. Dale Mayerson is a registered dietitian who has worked in long-term care for many years as dietary manager and clinical dietitian and has taught at several colleges. She is the author of Clinical Care Manual for Nutrition Managers and co-author of Menu Planning in Long-Term Care and Retirement Homes manuals. She is a longtime volunteer with the Ontario Seniors Nutrition and Advocacy Committee, advocating for long-term care residents and staff. The floor is yours, Dale.
Okay, so thank you very much, Tan. And I just want to check that I can show my screen. So I'm going to share my screen. Taeyang, yes?
Yes, go for it.
Go for it. Okay. I think I did it.
Perfect. We can see very well. Thank
Okay,
you.
great. So thank you everybody for joining today. I just want to mention a few things before we get started. First of all, I'm living on a street that is completely under construction. So if you hear noises beyond me, there's nothing I can do about that, and I apologize. The other thing is there's a lot of bullets on every page, a lot of points on every page of my slides, and I won't have time to go talk about each one, but just kind of a broad overview of each of my slides. Also, I'm not big on pictures and graphics, so you're just looking at print every time, so I apologize for that. And the last thing I just wanted to mention is that sometimes the inspectors use kind of broad sweeping statements for situations. So the example I pulled out was resident choice was not provided. And that might be one instance with one resident at one meal, or it might be everybody. And it's hard to know because the inspectors are very focused on maintaining privacy for the residents. And so a whole lot of explanation isn't given with the situations that I've come up with. So I'm just going to go through the slides here and skip that. So what I did was I went through the ministry inspection reports, and they are on a public website that is given to you at the bottom, the last bullet website, publicreporting.ltchomes.net, and that's free access to everyone. And I looked at about 146 notes, different, sorry, I'm just trying to make more space here. Okay. I picked letters of the alphabet to go through the slides, and I ended to go through the reports, and I ended up doing about 22% of all the homes in Ontario. Okay. A lot of the homes had multiple reports. Some were very short. Some were due to complaints, some were due to critical incidents, follow-up inspections, proactive compliance. It didn't matter to me. I went through all of them. I pulled out all the dietary information. And this is about the eighth time that I've done this. I think I started in 2013, looking at the reports and pulling out information. And of course, things changed over COVID. So I don't have, running year after year, but I do have some good information to share. So the good news is that 44 of the homes that I looked at didn't have any dietary findings at all, and that's good. That means the inspector went into the dining room, saw that things looked good, and didn't proceed further into the kitchen. The inspectors tend to come to the kitchen when they see things that are not right in the dining room to follow up. So altogether, as I went through the slides, I came up with about 19 different topics that revealed themselves, and 256 different inspector concerns. So each bullet point is the finding of an inspector. And like I said, some of them are not very detailed because they're trying to maintain confidentiality. Hand hygiene is the first issue, and it's always been an issue. But of course, since COVID, it's become a much bigger situation. So within those reports, I noted that 30 times before meals and snacks, staff did not provide residents with hand hygiene. So either when they come in the door to the dining room, when they're seated at the table of the dining room, the staff should give a little squish of hand sanitizer and show the resident how to rub their hands. And that was not done. And 12 times it was noted that staff didn't use hand hygiene for themselves between handling clean and dirty dishes. And if you've seen the dining room in action, that the same staff people are going to the tables with the food and then removing the dishes from the previous course away from the table. One staff was wearing the same gloves throughout the entire meal, which is useless. And one staff was found moving a clean snack cart with one hand and pulling a dirty laundry cart with the other hand. So those are some of the issues around hand hygiene. Also, the hand hygiene very often was past the expiry date, which is an issue as well. The staff said that residents who are well enough and mentally competent should be able to wash their hands before a meal and not need the staff help. And another staff person said that residents were only watching TV between meals, and so they didn't need to have their hands washed. So that's mentality that goes along with not providing the hand hygiene that's supposed to be done. Improperly providing service. Again, some of you may know that if a resident needs to be fed, total assistance with the meal, to put it in the more polite terms, that the person who is assisting them should be seated, should be making eye contact, should be making conversation, not having a staff person stand while feeding a resident in a downward angle. It's very unsafe. We train staff to sit, make conversation, eye contact, like I said, use just a small teaspoon instead of a tablespoon for feeding, watch the resident swallow safely, and move on to the next bite. So if somebody's feeding in a hurry, if they're feeding more than two people, if they're being impatient, then it's not going to work. We don't want anybody to choke or to have any kind of negative situation while they're in the dining room. Although some staff said they weren't properly trained, and that's definitely an issue because that should be done during orientation. And if it's not done during orientation, it seems to get missed altogether, which is another problem. When I do training with staff or even with volunteers, we had so many volunteers before COVID. I would have them feed each other so that they would know what it's like. I would give out information like close your eyes or tilt your head to the side or bend forward so that the person who was doing the feeding would have to learn what to do in those situations. For residents waiting for assistance with meals, the meals are not supposed to be served until assistance is present. So the inspectors noted, in some cases, 5 minutes, 10 minutes, 20 minutes, 160 minutes. And for one person who got the soup before the assistance arrived, the soup went from 173 degrees to 120 degrees in 5 minutes. And when the staff person came to feed the resident, they didn't put the food in the microwave to warm it up before feeding it to them. And these are things that are done with the inspectors present. The care plan, every resident has an individualized care plan, and it has to be followed. So in some cases, the food that is given is not the same as the food written in the care plan. For example, the resident was given a salad, but the care plan states no fresh fruits and vegetables. Or there's a peanut allergy and, sorry, there's a peanut allergy and the resident was given peanut butter. Regular portion instead of small portion. They're all the same. They're all the same idea that something's written in the care plan, but it's not being followed by the staff. Other certain situations in the dining room include the main course and dessert being served together. And again, if you know the regulations, you know that the meal is supposed to be done course by course, table by table. So the two courses shouldn't be served at the same time. The juices were poured before the residents entered the dining room, and that was that resident choice was not provided because the residents are supposed to be able to choose. And it doesn't matter if they've been there for 5 years and they've always picked apple juice. We're still supposed to ask, and this time they may say orange juice. And so we're supposed to be able to provide orange juice. The diet list not checked. So this is either a book or sometimes now on a tablet. Information about each resident, their diet, their texture, their likes, their dislikes, their allergies, intolerances, special needs, prune juice or whatever. All of those things are listed and they should be checked by the staff. And again, staff say, well, I've been here for a long time. I know what the resident needs. But even if the staff's been away for 2 days and there's been a change while they were gone, they need to use that book or that information to be able to make good decisions to help the residents and serve them what they need to have. In one case, the diet list was old and the inspector found 8 changes that had been made since the diet list had been printed. Again, it's challenging to keep the list up to date. As a staff person, I can tell you that that's a tricky thing because changes happen all the time. But it's essential that those lists are up to date to be able to give the right food and make sure that it's safe. 9 times, no assistive device was provided, even though it was documented in the care plan. So again, lots of these things come up over time. There's lack of communication, lack of, following up on situations, checking that things haven't changed. All of those things are very important to make sure that our service is good. So I've got swallowing concerns for solid food. Multiple times the wrong texture was served. Either it wasn't written down correctly in the care plan or it had been changed recently and somebody didn't know. In one case, the nurse changed the texture but didn't discuss it with the dietitian first. Or sometimes the PSWs who aren't on duty all the time or are working on a different floor don't understand what the residents need, or they just don't understand the basic diets or textures. In one situation, the resident choked on the wrong texture in the dining room, was sent to the hospital, and unfortunately passed away. And that's not a unique occurrence. That has happened in the past as well. It's just, sometimes it's not preventable, but sometimes it is preventable. And we need to be sure that, the staff are doing absolutely what they're supposed to do to make sure that it's as safe as it can be. Liquid swallowing concerns also happens. We've got honey thick, nectar thick. Sometimes those are very similar. The thickening product has to be used correctly. A lot of places now are buying products already thickened because the thickener might, work too well or work too fast or work too slow or, it's tricky. So there are gels, there are powders that are meant for thickening different fluids. There's also concerns about fluids that change inside the mouth. So for example, ice cream goes in solid but doesn't stay solid. It melts in the heat of the mouth. Same with Jell-O. So those foods are not supposed to be served to people who have swallowing difficulties unless they've been tested by a professional, and they know that that's okay to do. Another thing is like soup, which is a mixed texture. So vegetable soup, for example, you do it automatically so you don't think about it, but your tongue swallows the liquid, chews the solid, and then swallows the solid. And it's complicated. And if you don't have a swallowing disorder, it works very well, but there's like 50 or 60 muscles involved in swallowing. And if some of them aren't working correctly, then there's a big risk for a problem. And that's why we make so much emphasis on liquid swallowing concerns. In terms of Residents' Bill of Rights, the first one kind of blew me away that the PSW was angry with the resident and took away the resident's snack as a kind of punishment. The next one was medication was left on the dining room table for the resident. That is not supposed to happen. The staff is supposed to watch, the nurse is supposed to watch the resident take any oral medication. So any pills, they have to watch that the pills are actually being swallowed. Leaving them on the table and then walking away is not a good thing. No emergency plans in place or plans not updated. And emergencies can be anything big or small. Many staff are out, due to infection, or there's been an ice storm, the truck can't deliver the groceries, or the power's out, or the water supply is somehow tainted, and there has to be emergency plans in place for the kitchen, as well as the rest of the building. The next one, I'm sorry, kind of made me laugh. The resident was found in the storage room eating cereal from a box. I don't know where the storage room was, but somehow there was not good lock or not a good security, and the resident found their way in, and someone found them eating cereal. An open chemical bottle found in a resident area, and I did include that even though it didn't say it was a dietary related incident. It could have been housekeeping, could have been maintenance, could have been anybody. But we can't leave chemical bottles open in resident areas. It's just completely unsafe. It's like, oh, look at this nice blue liquid. I think I'll take a taste. It's just very, very risky. And the next one kind of surprised me. It's a fridge in a resident area, and because it was open to anyone, the inspector thought it might be an allergy or a choking risk to a resident who would just randomly open it up and take something. There are lots of fridges around long-term care homes in open areas, in resident areas, in pantries, in dining rooms, families who bring in food. There's fridges everywhere. So I was really surprised to see this. I only saw it in one inspection report. Menu communication is also very important. We're supposed to serve what's on the menu. So if the menu says peas, we're not supposed to serve carrots unless we have a real reason, and we should have changed the menu in advance of the meal service. So in the first case, there was the week 2 menu posted, but it should have been week 3. Condiments are an issue. Lots of times where, it could be tartar sauce, salad dressing, mustard or ketchup that's on the menu, but doesn't actually get served in the dining room. And residents always aren't going to remember to ask, oh, I really want tartar sauce for my fish today. It's supposed to kind of show up or be offered by staff. Different desserts on the menu and different desserts actually served, a different soup and dessert on the menu and served. And the next one also made me laugh. The cook made a menu change but didn't tell anybody, so that was obviously a problem and not supposed to happen. Maybe, sometimes the meat is not defrosted. It takes 2 or 3 days for a big chunk of meat to defrost in the fridge. Sometimes the supplier didn't send the right thing. Sometimes they're short of an item. It's okay to make a menu substitution, but we're supposed to let the residents know that it's changed. Menu planning, again, supposed to be approved, viewed by the residents' council, approved by the dietitian, approved by the nutrition manager, seen by the administrator, all before the menu is put into place. So if it's not put into place, then there's a problem. Things have to be looked at. So the first one, the menu wasn't checked by the dietitian or the nutrition manager. I don't know how that's possible, but that was in the report, and it was listed 3 times. 7 times the nutritional analysis wasn't done. The DRIs stand for the dietary reference intakes, and those are, they list every nutrient for every age group, so very valuable information and good to have. And there's a lot of computer programs now that do a nutritional analysis. but it has to be done before the menu is put into place. And in this 7 cases, it wasn't. Residents' Council needs to see the menu and have input into the menu before it's put into place as well. There's an annual survey done in every home in Ontario, according to ministry regulations again. And if there are menu comments, there should be some action taken, but in 2 cases, there was no action taken. Okay, one menu was using Canada's Food Guide instead of the DRIs, the dietary reference intakes. And our current Canada's Food Guide is a plate model. It really doesn't, it's not very helpful for menu planning. The previous Canada's Food Guide had certain numbers. I would say 5 servings of fruit and vegetables, each half a cup, for example. So it was mathematical. We could check right away on whether or not we were meeting the standards. But now the ministry's taken Canada's Food Guide right out of the regulations, and we're only left with the DRIs. Food temperatures have to be taken in the kitchen and before the meal service. So, and multiple times the temperatures were not taken in the inspection reports that I saw. And the last bullet says no temperatures were taken for a full month. And if the temperatures are taken, they need to be the temperature is, let's imagine roast beef and then potato and then vegetables. The thermometer is supposed to be cleaned between checking different foods. So if there is a bacterial infection in the beef, now we have spread it to the potatoes and the vegetables by not washing the thermometer or not using an alcohol swab on the thermometer before checking the next food. And in one case, I believe the scenario was that the resident was supposed to have assistance to eat. The soup was provided before the assistants arrived. The resident tried to feed themselves and spilled the soup and burned themselves. So that's another incident that happened. A focus on cold food. I think a lot of people have the idea that hot food can cool off and grow bacteria more than people think about cold food warming up and growing bacteria. So cold food becomes a different issue than hot food. Multiple times cold food temperatures weren't taken. So that would be desserts, it would be salads, certain kinds of side dishes that were refrigerated. And milk and cream that go into the coffee and tea and drinks that are served usually on a cart. There's a beverage cart that goes around the dining room before the actual meal gets served so that people can have their cold drinks available to them right away. So all of those things add up, and it's important to check the cold food, and a lot of times it's forgotten. Residents' Council, so 3 times the suggestions of the Residents' Council were not followed up I'm assuming for the menu or for some part of food services. And twice the Residents' Council was not shown the results of that annual resident and family survey. And like I said, the ministry requests. There's supposed to be compliance with an annual survey, although the ministry doesn't tell us what questions to ask, not yet. They're saying that they're working on a Ontario-wide home survey, but right now the homes can pick the questions they want to ask, but they have to do a survey once a year. Weight concerns, and we're going to just edge into some more clinical issues right now. Weight loss is the beginning of a lot of different problems. So if a person is losing a lot of muscle mass, as happens in long-term care, that people aren't moving around a lot, they lose weight, but they lose its muscle, which means that they're more likely to fall. They become more frail. They become maybe more stooped. Muscle is important to keep the body in good shape. And so if there's a weight loss that's unexplained, it needs to be followed up. Usually that's the nurses give a referral to the dietitian for weight loss problems, but sometimes, like everything, things get skipped or missed or not done the way they're supposed to be done. So in one case, the doctor ordered daily weights and they weren't done by the staff. The resident gained 5% in 1 month, but there was no follow-up done. Sometimes they send information to the dietitian and the dietitian doesn't follow up. Sometimes they didn't send the information to the dietitian, so the dietitian doesn't know. It can go a lot of different ways, and you can see that it's all a matter of problems of communication. Other clinical concerns, the 24-hour admission care plan wasn't done. The care conference was held, and the care conferences are held after 6 weeks of admission and then every year after. They held the care conference, but for some reason, the resident wasn't even invited. And I'm presuming the family also wasn't invited. Another case, the nutrition manager didn't have access to the care plan documents, and that's just wrong. The nutrition manager has to know what's in the care plans, just like everybody else who's providing care and services to the residents. The dietitian had no input into the policy and procedure about supplements. Those are the oral liquid nutritional supplements, Boost or Ensure, those kinds of products. Another one had nothing to do with dietary, but a code blue, what's a heart problem, was called in the dining room. And there was no equipment available in the dining room for that situation. It took precious seconds to go and get the equipment, the ventilator or whatever that was needed so that the code blue could be addressed. The dietitian ordered interventions in the resident chart, but it wasn't followed by staff. And then the last one, again, not a dietary issue necessarily, but still happened in the dining room. The nurse gave the resident their morning insulin, and the resident didn't eat breakfast. And by the afternoon, that resident was in the hospital. In this case, the home failed to ensure that adequate fluids were offered to residents in the home. And again, because of that kind of sweeping statement, we don't know if that's every resident every day, a few residents sometimes, we just don't know. But hopefully this statement is enough to make the home, change their policies and their processes so that adequate fluids are provided to everybody. And the next one was even more interesting. The nurse on duty didn't know how to administer our residents' nutritional support. And I don't know what that meant. I don't know if that was a tube feeding or if that was I'm not sure what it was. But the nurse didn't know how to do it, so they didn't do it. And they didn't ask anyone for help and they didn't ask anyone for information, and it didn't happen. And again, because we don't know what it was, we don't know how serious it is, but it's still, a gap in knowledge and in care. Twice there was skin breakdown and no referral from nursing to the dietitian. And one time the dietitian was aware of the skin breakdown but didn't follow up. And 5 times it was noted in the reports that the dietitian was not included as a member of the CQI committee. That's continuous quality improvement. The dietitian has something to add to that committee and should be included and is supposed to be included according to the regulations. And once the dietitian was not included as a member of the medication committee, and that's supposed to meet at least once a month, that's the doctor, the pharmacist, dietitian, head of nursing, whoever else is included in that committee. And that didn't happen. The meeting happened, but the dietitian wasn't invited. Okay, back to kind of more normal stuff. The dining room light fixtures were covered in dust. Sometimes, there's places in the dining room that need repair or need brightening or need fixing or need cleaning. And we just, the staff just doesn't see it anymore. I try to kind of make the analogy in your own home where, the furniture gets dusty and you kind of don't notice. The blinds in the dining room had streaks of paint. There were fluid stains on the walls. Part of the dining room wall was torn and not fixed up, and the dining room floors were sticky with food and drinks. So paints a very unpleasant picture in my mind. The main kitchen floor, this is a quote, main kitchen floor and 6 pieces of equipment had accumulated black dirt, and the staff and the manager couldn't confirm the last cleaning time. So there should be a cleaning schedule in every home and in every department. And the cleaning gets done. Staff initials are placed in the correct spot, and the manager checks it frequently to make sure that that's not an issue. That cleaning is done on a regular basis all the time by everybody. And not having that done is just, I don't know. Anyway, maybe unhappy to read that. The next one, food, dried fluids, and debris noted on the dining room floor before breakfast on numerous dates of the inspection. And to me, that's again, maybe a night cleaner that should have swept up before the next day, when staff arrive in the morning and when residents arrive in the dining room for breakfast, it should be clean. And it should be, there shouldn't be things on the floor that were lying there from the meal before, which was last night's dinner. Unsafe or broken. Both times this was the dish machine needed repair. The temperature wasn't meeting standards to wash and sanitize the dishes correctly. And in one case, there were no audits for the kitchen equipment condition or use. And auditing that it's part of continuous quality improvement, CQI, and there should be audits again, every department, all through the home, done all the time, and with an action plan for everything that isn't working. It's a very simple structure, the audits, but it's somehow hard to follow up with other things happening that seem to be that more time sensitive. On one hand, I can see the problems, and on the other hand, I see exactly how the staffing situation doesn't allow for every single tiny thing to constantly be fixed or addressed. Unsafe or broken. The keypad to the servery was broken. That's a big risk because then any resident could get into the servery where there's, equipment to heat coffee and tea, and there's a dish machine, and there's steam tables, and there's lots of possible ways for a resident to injure themselves. The key to the dining room was left in the lock, same story. The ceiling in the dining room was leaking and buckets were set up. And I did go back to check that that was more than one bucket that they were talking about. The steam table was rusty. The window cranks were missing, so the windows couldn't be opened. You can see the rest. I mean, black tape on the floor, the blinds were broken, peeling concrete. All of these are hazards, places for bacteria to grow for one thing, and then just safety risks as well. And I copied this from a recent newsletter that I got. So I don't know how many of you know about Santa's Health, but they do put out a daily long-term care newsletter. So if you can Google them, you might be able to sign up for a free newsletter that I get. It comes every day. So the Ontario, and this is about hospitals as well as long-term care, but Ontario Patient Ombudsman received nearly 5,000 complaints last year, with long-term care homes among the top concerns. Northern Ontario had the highest complaint rate in the province, reflecting regional challenges. And I just wanted to kind of let you know that their data is being collected from a lot of different areas. The calls that the ministry gets is one thing, the patient ombudsman is another one, the ministry inspections is another one, our own internal audits is another one. There's lots of ways to check and follow up and see what's going on and try to make things better. And so those are all of the issues that I came up with going through all of those reports. I think it was 146 homes, I said. And now we've got this, how do we fix this? What do we do? What's wrong and how do we make it right? So the first thing is communication within the department and between the departments as well. Nobody knows the residents like the PSWs. The PSWs are the ones that spend the most time with the residents. They know them the best. They know the problems the best. And talking to PSWs, for me as a dietitian and kitchen manager, they're gold mine of information. And communication is, respectful. Communication both ways. It's very important to make sure that all of the information is collected by everybody so that everybody's providing good care. If we can't provide care, if there's gaps in information. Again, another very strong relationship is between the nurses and the dietitian. Lots of things get solved when nurses and dietitians put their heads together and get things fixed. Staff not following instructions or tasks not completed or staff not properly trained. All of that comes into that third bullet. And then staff being rushed or working on unfamiliar units, which happened a lot during COVID. People were, lots of staff were away as well as residents being sick. And all that information has to be available for everybody. The care plan is the main document, and it should match the dining room list, the list that has all the patient and all the resident information on it. So there's a servery list. As I said, it could be on paper, could be in a binder, could be now on a tablet that has the diet, the texture, the likes, the dislikes, the allergies, the intolerances, all the special information. The MAR sheets have the diets. The MAR stands for medication administration record. So that's the medication that everybody's having. And that's also important to contain the diet and the textures. We know what needs to be ground. We know what needs to be given with fluids. We know what kind of fluids to give with the medication so that the residents can drink and take their pills at the same time. Should be a list on the snack cart. The snack cart and the dining room list should be, all of this should be identical information. Any diet reports that are online, any notes posted in the resident rooms, all of them should be exactly the same and have exactly the same information. It's just not safe any other way. And it's very easy to talk about, and it's very hard to do, to make sure that the information is the same everywhere. And it changes every day. Residents go to the hospital, come back from the hospital. Even somebody who temporarily has their dentures removed and needs to be on a minced diet for 2 days, and then the dentures come back fixed and then back to normal diet. All of those things are very time consuming to follow. A little bit easier now with computers. Some places are just completely computerized. They change it once, it changes everywhere automatically, but we're still doing a lot of work on paper. Training is essential, and ongoing training is essential, and face-to-face training is essential, because a lot of places now use an online training system, 8 hours of training a year, and they're supposed to watch it at home and I'm sure some kind of money for doing that, but face-to-face training is also still very important. So training the PSWs and the food service workers and the cooks on correct procedures, making sure all the dining room staff know how to feed the residents properly, checking that staff are doing they're following their job descriptions, following their work routines. So a job description is a list of the basic jobs that the person has. The job routine is more like 7 o'clock, do this, 7:30, do that, kind of a day by day breakdown. And it has to be up to date. And the staff can't take shortcuts. A lot of times new staff are trained by older staff, and they learn the shortcuts right away, instead of following the work routine exactly the way it's laid out. And managers updating the work routines so that staff always have the most up-to-date information as well. Find out what staff don't know and what they do incorrectly so that it can be fixed. Not being alert on the job. One of the things that we can do is conduct mock ministry audits. So we have the report, we have the audit that the ministry uses. It's not hard to go around the kitchen and the dining rooms and the serveries and find out what isn't up to par so that we can correct it for when the ministry shows up. We have to watch for problems and situations and report them. We have to be ready for inspectors all the time. We have to make sure that staff are doing what they're supposed to be doing at the time that they're supposed to be doing it, and making sure that everything is clean and making sure that everything is safe. And I wrote, consider resident safety in all areas. And honestly, in my heart, I mean, consider resident and staff safety in all areas, because lots of things can go wrong for staff as well. How they handle chemicals for one thing. If there's a proper step ladder in storage rooms, there's lots of small things for staff too that need to be considered. Poor oral communication. So again, talking to somebody if something is wrong, making sure that things get fixed when they're supposed to, sharing information and not being, never saying it's not my job. My example is that somebody once came to me and said that they couldn't find their mother's red sweater. And I'm like, well, I'm not really in the red sweater department, but took her down to the laundry, hooked her into the laundry manager, and they went through it together and, were able to look for this sweater. So that's just a small example. Not everybody's going to do that, but at least hand over the phone number of the laundry supervisor, some way so that a complaint, if there is a complaint, gets passed along and not just ignored. Trying to be the person that is, open and willing to discuss things, and staff should feel comfortable going to their own manager or another manager to get help. And especially on weekends or evenings when, not every manager is in the building. Conduct short surveys, and I totally believe in this, going to the residents and just asking a few simple questions. How was your food today? Did you have enough to eat? Was the service friendly? Was your hot food hot? Was your cold food cold? It's not terribly time consuming. And if you even talked to 3 residents a day, we'd get tons of information from just those small conversations. And with that, I just have to mention that I remember so clearly that I went to a resident, walking around a dining room, went to a resident and said, how was the soup today? And she said, oh, soup was good. And I said, great. And half an hour later, her daughter called me. My mother said the soup was awful at lunch today. And I said, I just talked to her. She said it was good. She says, well, she's afraid of you, but I'm not afraid of you. And I was like, I just wish she would have spoken up at the time. We could have, anyway. it was a little bit frustrating. Staff, I hope that family members believe that staff want to help and want to do a good job and want to look after your loved one. It's people don't go into healthcare just for the money. I mean, there's a drive to push people into healthcare, an internal kind of button that makes us want to be in healthcare. And I always think it's better if family is considered part of the team and staff is considered the other part of the team, we need a team approach to make things work. The adversarial approach, it doesn't seem to be helpful in the long run. So I would love to hear, if there's time, I would love to hear your opinions about what you just heard and what else we could do to help each other and ways to improve the situation. Maybe we'll all need long-term care one day. We can also make it better for ourselves in the future, right? So lots of concerns there. I just also wanted to point out the OSNAC FNAT website is very useful if you want to take a look at it. It's wide free for everybody. There's best practice documents. There's different tools for clinical and food service care. There's the ministry audit that I mentioned is there, and I've done a breakdown of each question so that the manager who's doing the mock inspection knows where to look in all of the different corners. Emergency preparedness documents. I tried to explain why we need to have that information handy for emergency menus, what we were going to do, what if we had to evacuate, and there's so many different things that come up through emergency ideas. So please take a look at the website when you have a minute, and you might find some interesting things there, and there's ways to communicate with the group. If for any suggestions you have or any improvements that we could make. And these are OSNAC's partners. I just wanted to kind of give a shout out to everybody who's involved with our organization, because we really appreciate the support. And here are our sponsors as well. And I just want to thank you for taking the time to participate today. And I hope that you have some questions for me or some comments. And thank you. And this is my email. If you want to get in touch with me by email, I would love to hear from you. Anything at all, for residents' sake, it would be great. Like I said, I'm doing this report 2 more times to different groups. And so if I can make it better, if I can, answer questions or solve problems or make things more clear, then that would be great. So thank you very much for listening today.
Thank you so much, Dale. You can stop sharing your screen if you would like, just so we have the full screen.
Sure.
And everybody, I invite you to ask your questions in the Q&A box, if possible. You can also use the chat. There's a couple of stuff in the chat. Dale, you should have access to it. It's at the bottom of your screen. So
Do you want me
either
to open it up?
yeah, you can open it up and you
Okay.
can a couple of stuff that Patricia has
Yeah.
shared if you wanna.
Yeah, staff, I agree with you, Patricia. Staff will get defensive. I mean, especially if from their point of view, they're trying really hard to meet, to meet the needs of the different residents. Sorry, I kind of lost my way here. Should I start at the top or the bottom?
At the top, most of it
Okay,
is our colleague Yoan who has
I
shared a
see.
few things.
Okay, I see.
But if you want to read a couple of the
Yeah.
comments.
So, again, before COVID, there were a lot more family members around all the time in the dining room, especially. And since COVID, I don't think that those people have come back, the volunteers and the family members to feed and kind of see what's going on. So it can be distressing. I'm just going to read this comment, Patricia. Um, it has been our experience that if a medication requires diet restrictions, no caffeine, for example, there's no communication between nursing and food services, even though there is a form. Yes, I agree. This is the communication issue. It's no matter how many times I look and no matter how many years I've done this, communication it always crops up. And again, a little bit better with computerization, but even so, you have to read what's on the screen to be able to get that information. So oral and written, both of them are important to make sure that things work out. Yes, ice machines, I agree with you. Again, ice machines can be a real hazard. They are kept clean. The scoop is kept separate from everything else in its own container and washed throughout the day. But yes, ice machines for sure are a hazard, a potential hazard. And then I would like to see less highly processed foods, especially canned fruits and heavy syrup. A lot of places now are using fruits in pear juice, um, just because they don't then have to keep separate for for people on regular diets versus people on diabetic diets. Just makes it so much easier, especially when you have to mince and puree it. So you have regular minced and pureed, and then you have regular diabetic, minced diabetic, pureed diabetic. It's a lot going to several dining rooms. Many residents have kidney issues. Yeah. If, again, it depends on the kitchen layout, depends on the cooking equipment, depends on the staff of, the cook's skills, on whether or not they're literally cooking from scratch or whether they're using a lot of what we might call convenience products, breaded chicken fingers and fish products um, or whether they're cooking from scratch. Again, we don't have time to bread our own chicken, bread our own fish. Those things are quite time consuming. And if one cook is making breakfast and lunch and the next cook is making dinner, which is usually how it breaks down in these homes with up to about, 120 or so people, um, it just becomes tricky to be able to do it. But yes, I would love to see less processed food. It would just be better for everybody.
There's a couple of questions in the
Sure.
Q&A box. I can read it to you. There's a question from Tina. Thank you, great presentation. How often does the ministry conduct inspections?
Okay, so I'm not exactly sure what their schedule is right now. It used to be at least once a year, but they come in now for complaints and they come in for critical incidents. So if something is reported, then they show up. But they may not do a full inspection of the whole home. They may only focus on the complaint or the critical incident unless they see something while they're there. So it's a little bit hard for me to determine exactly when they come in and how frequently they look, but I can tell you that they come without notice. Okay, I remember decades ago, they used to call ahead. They used to say, we're coming in for an inspection. And the home would hire more people to come in and clean everything, make sure everything was, it's kind of like having company for dinner at your house. Things are kind of normal clean, but then when you have guests coming, things are extra clean, you know? So they don't do that anymore. They just show up at the door. And that's the same with the public health inspector too. They just show up and how they find us is how we are.
There's another question. Do you have suggestions for how family councils can effectively contribute to discussions about dietary needs on a regular basis?
You can invite the dietitian, you can invite the nutrition manager to your meetings. Um, you can ask for a tour of the kitchen. I used to love giving tours of my kitchen. People were always astounded by all of the equipment, especially people who think that the food comes in the back door and goes straight upstairs, you know. The big soup pots and all of the different things. I always love to show that stuff off. Yeah, you can, again, you want to do it in a way that's friendly and helpful, not, you can inundate the nutrition manager with, your best recipes. And especially if there's cultural, issues, if you're, the resident is not familiar with all of the food being served on the menu and you want to offer something from your own culture, your own religion or whatever or your special holiday tradition or whatever, that would be great. But the nutrition manager has to also have time to go through it and be able to put it on the menu. But yeah, reach out to the kitchen management team and get to know what the kitchen looks like and get to know the service that's provided. And then maybe it'll be easier for you to submit helpful information that the management can use. That would be great. I used to love going to residence council meetings and family council meetings and get to know everybody. It's always a much more workable environment when everybody's on good terms and knows at least each other's first names. It's a warmer environment that way for everyone.
Got another question. Not being able to bring food into long-term care is often a big shock to caregivers. Do you have any tips on how caregivers can adapt to this and be part of dietary decisions?
Well, there might be a food committee that you might be able to get on. I haven't actually heard that you're not allowed to bring in food for your loved one. Um, have I we always allowed people to bring in food. It had to be labeled, it had to be dated, it got thrown out after a certain time period. Those things happened. Like there were rules around bringing in food, but we never stopped anybody from bringing in food. There's some issues with bringing in birthday cake and offering it to everybody who may not, be on the right diet or texture for it. Those were issues. But if you're only bringing in food for your loved one, then it shouldn't be a problem if there should be a policy, a home policy about food brought in, and you should find out what that policy is. Because a flat no doesn't sound right to me. It's their home. They're supposed to be able to eat, if somebody brings in a treat, a cultural delicacy, whatever, then sure, they should be able to have it.
I don't see any other questions. Oh, there's just one that came on in the chat. Um, is there a summary of the slides or text available? So the slides, we can send it to everybody. Right, Dale?
Yeah, absolutely. Sure.
Yeah.
I didn't
So,
do all this work not to share it. I really want everybody to see, the issues without, hopefully without blame, hopefully as a quality improvement study, that this is what we have to fix, and then how do we get that fixed? Rather than, staff are lazy or, whatever. I mean, I've heard lots of different things going both ways, over the years. Um, and it's frustrating when I think that there's not an appreciation for the tension on both sides, that your loved one is not living with you anymore, or not independent anymore, whatever. And there's a lot of, I mean, I've seen, and I have a 97-year-old mother, so I'm, I'm right on board. Where there's, feelings of guilt and feelings of anger and feelings of, not doing right by the person. And we're all just doing the best we can. And we're learning as we go, and we're trying to do the right thing. And, tomorrow hopefully will be better. And, it's sometimes tough for each side to feel the empathy that maybe there should be more of.
and yes, I mentioned it at the beginning of the webinar, but this session has been recorded. So if you joined in the middle, you can watch the recording on Family Council's Ontario YouTube channel, probably next week or the week after. So I'm just looking, I'm not seeing any other questions come
Okay.
up.
I
Yeah.
just want to say, I hope I didn't go too fast. I know I didn't read every bullet point on the page, but I just wanted to highlight there's so many different issues, and from a whole variety of different, areas. And so, we have to address them one by one, kind of make sure that, we can fix things and we can make the changes. And then once we make the changes in our home, we spread it to other homes. That's what OSNAC is for, to spread out the knowledge and the experiences, and really make things better. Because all of us might need long-term care one day. Who knows, right? We want to, my joke is that when I'm in long-term care, I want somebody to ask me at dinner if I would like red or white wine with my meal. It would be something a little bit, I don't know, more fun to be part of. So anyway, thank you everybody for listening, and I appreciate your time, and I hope you got something out of this.
Thank you so much, Dale. And if anybody has any questions following the webinar, you can always email me, or Dale has left her email address as well. So if you want to reach out to her directly, feel free to do so. And like I mentioned, this webinar has been recorded, so you can view it again or share it with anybody who will be interested. And thank you so much, Dale, for this wonderful presentation. It is a joy to collaborate with OSNAC, and we're happy to continue this collaboration. So if any of the participants here, if you have any topics that you would like us to cover, any questions, we are more than welcome to receive those feedbacks.
Yes, we would love to
Um,
do more presentations, and you know educate people about what we do, and get your ideas and opinions too, and that would be great.
Absolutely. We're getting a lot of great comments in the chat thanking you for
Okay,
this
great.
presentation. So,
I'm reading them as fast as I can, not trying to break eye contact with you.
no worries. And yes, so this whole week, Family Councils Ontario is hosting events 12 to 1 p.m. It is our Innovation Summit. We have our next event tomorrow at 12 p.m., co-hosted by Behavioral Support Ontario, titled Personality Disorder in Older Adults, Understanding the Person, Building Skillful Approaches, and Fostering Wellness in Care Teams. So if you are interested in that, the registration link that you use to sign up gives you access to the full programming. So we would love to see you there at 12 p.m. Dale mentioned patient ombudsman throughout her presentation too, and we have actually a session with patient ombudsman on
Great.
Thursday. Better experience, better healthcare. That's also at 12 p.m. So you're welcome to join us for that. So thank you so much. If you have any questions, please reach out to us, and we're so happy to have you at our webinar, and we look forward to seeing you next time. Have a good day, everybody. Thank you.
Bye, everyone.